Good evening and welcome. I'm Jillian Kumagai and I'm the director of Stanford Health Library. Thank you for joining us for our talk tonight on lymphedema. It's my pleasure to introduce our speaker, Dr. Stanley Rockson. Dr. Rockson is the Allan and Tina Neill Professor of Lymphatic Research and Medicine at the Stanford University School of Medicine. As a professor of medicine, Dr. Rockson serves concurrently as Stanford's Chief of Consultative Cardiology and the Director of the Stanford Center for Lymphatic and Venous Disorders. Throughout the talk, please enter any questions in the Q&A box at the bottom of your screen, and at the end of the talk, Dr. Rockson will answer as many of those questions as possible. Dr. Rockson, I'll turn it over to you.
I am delighted to be back at the Stanford Health Library, and I'm delighted that those of you that are here are interested in hearing about the topic of lymphedema. Now, lymphedema really doesn't have anything much to do with getting married, but I thought the old saying about what a bride needs was useful to highlight some of the features that I'll be talking about this evening. So not in any particular order, during the course of my talk, I will talk about things that are old, things that are new, some ideas and concepts that are borrowed. And blue really means nothing more than the fact that it isn't a very happy circumstance when somebody encounters the problem of lymphedema in themselves or in a family member, whether it is a cancer-related issue or something else. So that's why I put in the word blue. I can understand why somebody who finds out that they have lymphedema might be a bit blue, and hopefully what we'll talk about tonight will help to dissipate some of those concerns as we make progress for this disease. So this is the problem that we're talking about tonight, and let's launch into it. So I know that the context of this talk is very much about cancer-related lymphedema. That is often the area where we end up talking about this, and you can certainly see not limited to these cancers, but certainly highlighting these cancers in which the treatment of the cancer can lead to lymphedema as a consequence of even successful treatment of the cancer itself. But there are other causes of so-called secondary or acquired lymphedema, and we're going to talk about what lymphedema is in more detail in a moment. But just bear in mind that there are a host of causes for lymphedema, for which cancer may be the most important one in the Western world, but not the only one. We think that there are somewhere between 5 and 10 million individuals in the United States alone who have this problem. So it is by far not an uncommon disorder, despite the fact that many of you who are listening who may be living with lymphedema may have encountered some responses on the part of healthcare personnel that made you think that perhaps this was some kind of a rare condition, when in fact it's not. I want to say just a word about so-called primary lymphedema. Primary lymphedema is one that is not caused by another disease or by another event that happens during life. Now, in contrast to secondary lymphedema, the primary form is a rare disorder. There are under 50,000 individuals with primary lymphedema in the United States, which classifies it as a rare disorder based upon the denominator of the US population. People are sometimes confused between the term primary and the term congenital. Congenital lymphedema, meaning it's present at birth, is a component of primary lymphedema, but the majority of people who develop primary lymphedema manifestations do so at a later time point in life. So about as much as 80% of this total subgroup will present for the first time with lymphedema as a young adult during puberty or shortly after puberty, or often in the late or early 20s. There is another small proportion of primary lymphedema that appears after the age of 35. And the medical term for that is lymphedema tarda, meaning onset later in life. This is probably a degenerative condition of the lymphatic system. It may be on a genetically predetermined basis. We really don't know very much about it yet, except to understand that perhaps in the US at large, there might be 5 to 10,000 individuals with this condition, so not very many. When we talk about the staging of lymphedema, it will help to highlight what it is that we are talking about with the disease itself. So what you see here is the staging classification of the International Society of Lymphology. And as you progress down this list of stages, you will see that the fluid accumulation in the tissues is progressively diminishing as the structural changes in the tissues supervene. So this is going to be a little bit of a snapshot of what I'll be talking about later on in the talk, which is to try to understand where does all of this tissue remodeling come from in lymphedema. Now, I also want to point out that there is a stage 0 of lymphedema, and this is relevant to patients who are undergoing or have recently undergone cancer treatment, because we do recognize that the earliest stages of lymphedema will not present as overt swelling, and yet there are detectable abnormalities that may be treatable and that may in fact be reversible. So it's very important to undertake surveillance for stage 0 lymphedema. That's what we do here at Stanford. And we use this technology. Here's the first borrowed idea, because the way that we detect lymphedema when it's in stage 0 at Stanford and at many places around the country now is by using a technique that is more commonly called body composition analysis. So in this case, the body composition that we're screening for is the retention of fluid in the tissues. And we can detect this with a simple device that allows us to look for the presence of this fluid before the examining eye or fingers can detect it, before the patient herself or himself might even be aware that there's any swelling present. And we feel that when we detect this at an early stage and aggressively treat it, we can reduce the eventual development of lymphedema by perhaps as much as 30%. So it's certainly well worth the effort. At Stanford, we endeavor to identify all the people at risk for lymphedema and to monitor them at least on a quarterly basis using this kind of technology called bioimpedance spectroscopy. Now, there are more sensitive ways to actually look at the problem of lymphedema once it becomes developed. And in some cases, even stage 0 lymphedema can be detected in this way. This is an example of what is considered the gold standard for lymphedema imaging. This is called radionuclide lymphoscintigraphy, or LSG, as it's sometimes abbreviated and referred to by patients and by their healthcare professionals. So let me talk you through what we're looking at here. So this is a patient with lymphedema of one arm, which is this abnormal arm, and I'll point out the abnormalities in just a moment. In order to detect this lymphedema, we inject a tracer compound into the skin of the hands at the base of the fingers. This is a tiny needle to inject about 1/10 of a milliliter of fluid. And that fluid is taken up by the lymph channels and carried to the lymph nodes that drain the arms. Now, this is the normal side, and you can see that there's very dense accumulation of this tracer in the lymph nodes inside the left armpit. This is the left arm, and that material has traveled from the hand all the way through the lymph channels to the armpit. On the abnormal side, in this patient, you will see that there is no uptake by the lymph nodes in the right-sided armpit region, and you see this very dense staining of the tissues along the path that the lymph fluid is supposed to travel. That's what we call dermal backflow, and that is a very key component of the presentation of lymphedema. It is the back leakage of fluid out of the lymph system back into the tissues. So this is a patient with lymphedema of a single arm as detected by LSG. Now, we've developed more sophisticated techniques even than lymphoscintigraphy, they mainly have surgical applications at this point, but utilizing a similar technology of introducing minute quantities of a fluid into the skin where the lymph vessels reside, we can detect the flow through the lymph channels by using the fluorescent characteristics of the material that we inject. So this is called near infrared fluorescent lymphography. This is a technique we also use at Stanford, but again, primarily in a pre-surgical mode. Here again, when the lymph system becomes abnormal, we see this back leakage of fluid. It's very similar to what I showed you previously that identifies this as a lymphedema leg in comparison to the normal leg on the other side. Now, the difference between lymphoscintigraphy and this near infrared fluorescent technique is that this technique allows us to actually see the channels themselves as opposed to just seeing the evidence of the transport. And so that becomes very useful to surgeons who need to understand more about the lymphatics and their abnormalities. We can also see the lymphatics by MRI. And once again, we rely on the technique of injecting materials into the skin in order to do the proper imaging. Remember that when doctors work on your blood circulation, they are working on a conduit that goes in a circle, so you can enter the conduit at any point, like a vein at the elbow level, and introduce something that will affect the blood overall. The lymphatics are one-way streets. You can't enter them at any point. You have to enter them from the direction in which the lymph will flow, which is why we have to inject material into the skin. But in this case, we use the contrast material that's typically used for MRI, which is called gadolinium, and we inject a dilute solution of gadolinium into the skin, and then we can very clearly see the lymphatic channels. And again, this is a very useful technique when we need to know much more precisely what the lymphatic network looks like. Now, let's go back and talk a little bit about the disease itself, now that we've talked about how it gets distributed in the population and how we detect it. So here's one of the old components in the old, new, borrowed, and blue schema. When I entered the field of lymphatic biology and lymphatic medicine in the early 1990s, this was the prevailing concept that the lymphatics are a kind of sewer system that get rid of toxic waste and fluid along with it, and that when you get lymphedema, you have some kind of a clog in the sewer system, and what we need is the Roto-Rooter man to come in and open things up. And this is clearly, we have learned over the last 2 or 3 decades, an oversimplification and actually not even a correct concept. So I'm going to talk you through what the lymphatic system really is, and therefore what happens in the disease process of lymphedema, which is a failure of this very complex and intricate system in the body. So we do understand that when the lymphatics fail at a very early stage, beyond stage 0, but into stage 1, we are going to see that the affected parts of the body start to swell, and the swelling is due to the accumulation of fluid, because the amount of fluid that appears in the tissue at any moment in time, and we have this throughout our bodies, that's why the lymph system exists. The amount of fluid that appears is slightly more than what the lymphatic system is capable of transporting on a minute-to-minute basis, and therefore there's a backup, a little bit like a traffic jam at rush hour. And we can detect this fluid by eliciting a physical finding called pitting, which means that the doctor or the examining person will exert pressure at the skin level with an examining finger, and with that, the fluid that is in the tissues can be temporarily pushed out of the way, leaving a pit or depression that will fill itself in within a matter of seconds to minutes, but this tells us that there is excess fluid in the tissues. What happens in lymphedema is that, and it relates to the staging system that I talked about a moment ago, as we watch the progression of this disease over time in individuals who have lymphedema, we find that that pitting quality is progressively lost, even though the swelling of the limb persists, and the persistent swelling in the absence of pitting becomes more and more predominantly a reflection of overgrowth of the cells and tissues of the affected limb itself. So what starts out as an enlargement of the limb by fluid accumulation becomes an enlargement of the limb increasingly by the accumulation of cells and biological material that is not, strictly speaking, extra fluid, which explains why it is an incorrect concept to just think of lymphedema as a sewer system or a plumbing problem, because it eventually becomes a structural problem of the affected limb itself. And as the disease progresses in some individuals, the effect on the tissues can become quite profound, so that the overgrowth, for example, of elements of the skin will actually become overt as abnormality of the skin itself. But what's happening on the surface of the skin is reflective of what's happening in the tissues underneath as well. So what I want to emphasize is that beyond being just a simple system of pipes for the drainage of fluid, we need to understand that the lymphatic system is a very complex immunovascular network. It is most definitely part of the circulation. Without the lymphatic system in place, the rest of the circulation would collapse within about 24 hours, because the circulation depends on the return of tissue fluid to the heart so that the circulating blood volume can be maintained. And the reason that lymphedema supervenes with this frequency in cancer survivors is because to treat cancer, we need to sample lymph nodes or remove lymph nodes as part of the surgical treatment. And the lymph nodes are part of the immune system. And what connects all these lymph nodes to one another and connects the lymph nodes to the tissues themselves, again, is the lymphatic circulation. So the lymphatics are really a profoundly important part of the body, because they represent an integral part not only of the circulation, but also of the immune system. And therefore, it is very intelligible that when this complex network fails, that there will be very profound consequences on the tissues themselves. So with that in mind, and understanding that what has been perplexing to me and to doctors in general is to understand, why do these tissue changes occur and can they be treated? This has led me down a path over the last 30 years, really, to develop a drug approach to try to harness the power of the body to reverse and ultimately, we hope, potentially to prevent lymphedema. Now, in work of this type, as many of you I know are aware, we rely heavily on observations that we can make in animal models of disease so that we can identify the basic principles and identify efficacy and safety and so on before we need to progress to the stage of treating people. So I'm going to describe some of the animal work that we've done that has led us in this new direction of potentially treating lymphedema with drugs and potentially reversing the damage related to lymphedema. So early on in my career, I developed an animal model in a mouse. So we call that the murine model of lymphedema. And we chose to look at the mouse tail, which you see in the center of this figure. The mouse tail vaguely resembles an arm or a leg. And what we thought is that if we could damage the lymphatic circulation of the tail, we would allow the tail to develop lymphedema that would be a kind of model for the sort of swelling that occurs after breast cancer treatment or prostate cancer or gynecologic malignancies in the leg. And this model quite elegantly allows us several issues. Number one is the lymphedema in the mouse develops very quickly after we damage the lymphatics. So we can study the time course of the development of the edema. We developed a methodology to actually very accurately measure the increase in volume of the tail by taking digital photographs of the tails and then deriving information from those digital photographs that allow us to very accurately estimate volume and volume change. And because we're interested in the tissues, we can also harvest the tissues from the tail and study them under the microscope and study their molecular attributes. So what we found in the mouse, very similar to what we see in human specimens, is that over a very short period of time after developing lymphedema, there is this tremendous overgrowth of the skin and all the elements of the skin, all the cells, dilation of lymphatic vessels within the skin, and all of the attributes that we ascribe to human lymphedema and its counterpart in normal skin, we see in the skin of the lymphedema mouse and the normal mouse, respectively. And furthermore, what was very gratifying to observe is that we know that in normal skin where there are lymphatics, the lymphatics don't ever carry a lot of fluid at any moment in time. So typically in normal skin, we don't see them. They're collapsed because they have very little fluid content. But when an individual develops lymphedema, the lymphatics dilate in a very dramatic fashion. And that's exactly what you see in this mouse specimen. We've used what's called immunohistochemistry, so we can stain the lining cells of the lymphatics in a very specific way to know with certainty that we are looking at lymphatics. And you can see that there are these big dilated channels that typify lymphedema that are not present in the normal skin. Now, what is even more gratifying than that observation is that as we developed drug approaches to try to reverse what's going on in the tissues in lymphedema, we found that these big dilated lymphatic channels actually regress. As the lymphedema goes away, so does the abnormality in the lymphatics themselves. So it is an indirect evidence that in treating the lymphedema in the ways that we have been, we are actually reversing the attributes of lymphatic malfunction. And I'll show you some other examples of that as we go on in the talk. Well, early on, what I thought would be the direct approach to try to develop a new drug, I had very little faith that we could actually repair the lymphatic damage to these microvessels themselves, because it seemed like that was almost an impossible task. But what I know as a cardiologist and as a physician is that for very many of the chronic disease states that we treat with medication in human medicine, we're not necessarily rectifying the underlying abnormality, but we're helping the body to coexist more normally and in a more healthy fashion with the problem that is present. And so I thought that what we ought to do is to harvest tissue from lymphedema tails and compare them to control tissue to try to determine what are the molecular signals in the tissues themselves that will tell us how they are responding to the presence of lymphedema. Because if we do that successfully, then we've identified potentially a path to rectifying the problem. And what we discovered when we did that is that almost everything we were able to detect in mouse skin with lymphedema had to do not with fluid or with the circulatory functions of the lymph system, but specifically was related to immune function and to inflammation. It was really a dramatic finding that was very unexpected at that point in time in circa 2005. And this allowed us to elaborate a model that we still work with, in which we think that the various elements of lymphedema, as they become established, ultimately lead to a chronic inflammatory state that actually drives the lymphedema forward and that stimulates these changes in the tissue. So we decided that if we could determine the specific attributes of the inflammation in lymphedema, we might have a target for treatment response. So this became our very focused approach to lymphedema, was to understand and to combat the chronic inflammation that we now know is present in lymphedema. So based upon that initial analysis, we determined that in lymphedema in the mouse tail, there is excess activity of this relatively well-known tissue enzyme called lipoxygenase, or we call it 5-LO. And 5-LO produces a series of molecules that drive inflammation in the tissues. Now, for any of you that know about the problem of asthma, we know, for example, that some of the anti-asthmatic drugs can reduce the tissue inflammation that leads to asthma by blocking the downstream products of 5-LO that occur in the airway. But there are a whole variety of these molecules that are produced when 5-LO is stimulated. And so we decided, because this was a relatively unexpected finding, mainly the talk about 5-LO back in those days was in relation to airway disease, we decided to use a drug that could block this enzyme. And we chose to use a drug that is a non-steroidal anti-inflammatory drug. It is a prescription drug, and we repurposed it. So there is a little bit of the borrowed idea. The drug that we decided to test simultaneously blocks 5-LO, and it blocks the pathway that is blocked by most of the other over-the-counter anti-inflammatory drugs that I believe you're probably all familiar with. Drugs like Advil and Aleve and ibuprofen are all capable of blocking this cyclooxygenase pathway. Now, I want to hasten to say all those over-the-counter medications like Motrin and Aleve do not solve the problem of lymphedema, but we chose to use a cousin of those drugs that also blocks this pathway because we thought, based on what we learned from the mouse tails, that it might have some success. And indeed, that was the case. When we give the drug to normal mice, their skin remains normal and nothing untoward particularly happens. When we give the drug to mice with lymphedema, well, let's say it this way, when we use a placebo for the drug, we see that nothing happens. But when we give the drug systemically, in this case, we gave it by injection to the mice, but if we were giving it to a person, we would give it by mouth. What we found is then, in as little as 2 weeks after giving the drug, the skin of the mice, as well as their lymphedema, completely resolved. We basically turned the lymphedema into a normal mouse tail, but even more importantly, because we were so focused on the tissue changes of lymphedema and the irreversible nature of that in the human disease, we were able to show that the structural changes were also reversible, very unexpected. And we even showed that the scarring process that is typical of late lymphedema, and scar typically is thought of as an irreversible phenomenon, we found that even the scarring was able to be reversed to a measurable degree. So this was very, very exciting and led us to next undertake some human clinical trials that we performed over the next 5 years or so. And to cut to the chase, we were able to conclude both an open label and a placebo-controlled component of a trial of the anti-inflammatory drug given by mouth in human lymphedema, and were able to show that we could do in humans what we were already able to do in mice. Because of the observations that we made in the mice about the restoration of normal tissue anatomy and reversal of fibrosis or scarring, we decided to measure as an endpoint the resolution of increased skin thickening that we tend to see in lymphedema. So this is one of the subjects that was enrolled in that clinical trial. This was a woman who had lymphedema from a breast cancer treatment. She was free of breast cancer when we enrolled her. Normal skin thickness, when measured by caliper, would be about 2 millimeters or so at this particular location. Her skin thickness at the initiation of the trial was about 35 millimeters, so more than 10 times, almost 20 times normal. What you see at the end of her enrollment in the trial, she took the drug for 6 months, is that her skin thickness restored itself almost completely to normal. This is about 4 millimeters, which is still larger than we would have measured on her normal arm, but pretty close to normal, and certainly a dramatic change in comparison to where she started. The only change that occurred during this period between picture 1 and picture 2 was the addition of this drug, which she took on a daily basis over that period of time. We actually did skin biopsies in these participants in the clinical trial that was published, and we showed that a variety of their changes under the microscope also normalized in response to treatment, which is what we would have expected from the mouse observations. And not surprisingly, when we used immunohistochemistry to look to see if we were suppressing 5-LO activity in these patients, we did in fact find that that was the case, which is the expected response to a drug that is supposed to suppress that activity. Now, this was a wonderful answer in many ways, but it raised more questions. One of the issues that came up is that between the time that we completed this trial and published it, the FDA decided, after a couple of decades of looking closely at the Motrin and Aleve family, I'll call it, which includes the drug we were studying, but not limited to our drug at all, the FDA decided that these drugs, particularly when used chronically, may have adverse effects on the cardiovascular system. So it gave us pause, of course. We didn't want to push wholeheartedly in the direction of a drug that would solve one problem and create another. We also were curious to know, since we were dealing with a drug that treats 2 different inflammatory pathways concurrently, which of them was responsible for the benefit? Was it suppression of 5-LO, or was it suppression of cyclooxygenase, or both? And in order to answer that question, we undertook a series of additional studies on lymphatic endothelial cells in tissue culture and on the mouse model itself. And what we were able to determine is that, yes, in fact, it is the lipooxygenase activity of the drug that is responsible for the clinical benefit and not cyclooxygenase. What we were able to identify is that one of the downstream products of 5-LO, called LTB4, is actually the molecule that drives lymphedema, and that when we block LTB4 production in a much more specific way than we were able to do with the initial drug, we can actually reverse the lymphedema in a comparable way without the adverse consequences of the nonsteroidal anti-inflammatory effects that the FDA shone a spotlight on. And what we discovered in this work is that LTB4, when it is present in excess because the individual has lymphedema, that molecule actually blocks the lymphatic system from repairing itself. So let me show you what amounts to an LSG, or lymphoscintigram, in the mouse tail. This is what a normal mouse tail looks like, and all of the green kind of hexagons that you see are the lymph channels that are traveling through the skin of the mouse tail. What happens in lymphedema is very similar to what I showed you on the LSG, which is that there is pooling of lymph fluid in the tissues, and we lose the normal functional architecture of the lymphatics when lymphedema is present. When we take this mouse and give it a drug to specifically block LTB4 production, in as little as a week, we see almost complete restoration of the lymphatic functional anatomy that is lost because of the lymphedema. Let me show you a little more compelling evidence of that. I'm first going to show you a placebo-treated mouse. So this mouse had injections of saline or salt water. This is where we damage the lymphatics in the mouse tail. Here's the swollen mouse tail, and this is where the lymph should be flowing. And while you look at this, this is the equivalent of one of those fluorescent lymphoscintigrams that I showed you earlier on. We really see no flow from the mouse tail toward the body of the mouse, meaning there's no lymph function there. This is what happens to a mouse if it is treated with this LTB4 blocking drug. Watch over here and you will begin to see spurts of white coming across this channel. There it is. There is the lymphatic flow that has been restored, going back to the body of the mouse, allowing the tail to drain itself. And if we looked at this mouse a few days later, the lymphedema would resolve and the tail would no longer be abnormal. So that is direct evidence that blocking LTB4 allows lymphatic flow to be restored, even in a vessel that has been surgically damaged. Now, what we attempted in all of this work is to show whether or not given classes of drugs might have a comparable effect. And what we found is that when we block LTB4 or anything upstream of LTB4, we restore the mouse tails to normal. But if we use ibuprofen or other drugs that work on different components of the pathway of 5-LO that are not involved with LTB4, we have no effect at all. So that's really what this graph demonstrates. It is only blockade of LTB4 production that restores the mouse to normal. We were able to demonstrate that in both mouse lymphedema and human lymphedema, the serum, the blood, the circulating blood, contains elevated levels of LTB4, which is indirect evidence that our hypothesis is correct, and that the mouse model and the human situation mirror one another. So the end result of all of this work was to decide that LTB4, a downstream product of 5-LO, which was our original target, is really the target that we should be focused on in drug development. LTB4 is a very complex molecule that has a variety of effects in the body, and we don't really have time to talk about this tonight, but a molecule of great interest, and it retains interest for us in our work related to lymphedema. We conducted a small trial of the same drug that we used in the mouse model. This is not published yet, but it was a trial that we could not take to completion for budget reasons. But I want to show you a compelling set of photographs from one of the people who was enrolled in this trial and received the active drug. She took the drug for 6 months during the trial. This was her leg prior to the enrollment in the trial. She had lymphedema of the left leg on the basis of prior cancer treatment in the pelvis. And just to show you how exciting this might be, this is her leg 18 months after she stopped taking the drug. The only thing that she does to take care of this leg, which is now normal in size, is to wear a light level of compression. So indirect evidence, we cannot draw conclusions from a single patient. That's why we do clinical trials on groups of patients. But in this one patient, we see that the notion that the drug can allow the lymphatics to heal themselves and reverse lymphedema appears to be demonstrated. And now I'm going to spend the last few minutes before I entertain your questions to tell you about an exciting new human trial that we are imminently launching at Stanford. We believe that we will start enrolling the first patients during the month of April. All of our legwork in getting this trial established is nearly completed. And we will once again be studying a specific antagonist of LTB4. Now, before I tell you the specifics of this clinical trial, I want to make sure that everybody understands how complicated clinical research is. When you do research on a new investigational drug, you have responsibilities in a broad array of directions. You certainly have responsibilities to your patients and to the subjects enrolled in the trial, but you have responsibilities to a variety of institutions that are overseeing the work that you're doing, and most importantly, in this case, to the Food and Drug Administration, which is why the whole design of clinical trials is so complicated and so important to adhere to the basic principles. So in this particular trial, we will be studying human lymphedema that affects the arm. And we've chosen to test the arm, not because we think it's more important than the leg or different than the leg, but patients with arm lymphedema are more similar to one another than our patients with leg lymphedema, and certainly mixing them together would create big dissimilarities. The more dissimilar the patients are within a given population that you're observing, the more subjects you have to observe in order to reach a valid conclusion. We want to get to the endpoint as quickly as possible. So we've decided to use arm lymphedema as a way to get to that first endpoint really quickly as we can, so that we can then broaden our observations to include all categories of lymphedema, which I believe will ultimately be possible for this drug approach. So we will be studying patients who have lymphedema of one arm only. They must have lymphedema that has at least a 6-month duration. They can be male or female. They need to be adult patients, and we put an upper age limit primarily because, as we all understand, the older an individual is, the more likely there are to be comorbid conditions, additional disease states that are present. And if any of those additional disease states create a clinical event while the individual is in the trial, then the FDA has to presume that that event was caused by the study drug. So if we enroll an 85-year-old patient who has a stroke, for example, during the period of time that we're giving the drug, that stroke will be ascribed to the drug, even if it may have nothing to do with the drug and has to do primarily with the patient's age. So just to understand why we have an upper age limit. So if an individual is enrolled in the trial, they will be fully evaluated prior to formal enrollment for all of the reasons I just discussed. If the individual meets all of the superficial requirements of the trial, that individual will be given the opportunity to sign an informed consent document in order to participate, and then the next events will occur. The individual will be monitored carefully throughout the duration of the study. Anybody who's in a clinical trial, not just this one, but any trial that exists, has the opportunity to withdraw voluntarily at any time that that individual chooses. We hope that doesn't happen, because enrolling in a trial and not seeing it to completion confounds our ability to interpret the data, but we would never stand in the way of somebody who had a valid reason in their own mind to withdraw voluntarily. And if the drug does work, then of course the individual has the opportunity to experience any of the potential benefits of the investigational drug. And this might be years, of course, before this investigational drug is commercially available. I didn't mention yet, I don't think I mentioned, that this particular study is what we call an open label trial. So unlike the prior work that we did, and unlike many, many human clinical trials, there will be no placebo exposure within this trial. You don't get randomized to a sugar pill. Everybody who is accepted for enrollment and wants to enroll will receive the active LTB4 antagonist during their enrollment. And of course, there is a philanthropic nature to clinical research participation, because you're potentially helping not only yourself, but the general community of patients who have similar problems to yours. So if you're in a trial, though, we can't guarantee that anything favorable is going to happen based upon your enrollment. We're trying to find out if it's a favorable outcome. So we can't guarantee that at outset. We do not reimburse for any personal expenses that are accrued on the basis of participation. That is to say, we don't pay your gas mileage, we don't pay your parking fees. We pay for everything related to your medical care as it relates to the clinical trial. So everything that we do in the trial is covered by the budget of the trial, but not any incident. If you have to get a babysitter so you can come in for your clinical trial participation, we can't pay for the babysitter. We will not ask you to incur any medical expenses for your participation. That is to say, everything that happens in the trial, we do take care of. So here is a formal description of this trial, which we call the HEAL trial, HEAL, that's our catchy acronym. It is a pilot trial of acebelostat, which is the name of the active drug. It is to be used for single-arm lymphedema. This is pretty much what I've already described to you. We will be tracking the thickness of the skin by ultrasound of the skin during the trial. We'll continue to measure skin thickness by caliper as well. And we will be enrolling 70 subjects, and then we will analyze the outcome at the end of the trial. As I said, all patients will receive the active drug. There's no randomization to placebo. If you are involved in this trial, actually this slide is a little incorrect. There are actually 5 visits, but visit 1 and visit 2 occur 24 hours apart. So we see you initially for the enrollment visit, at which time we have to draw lab work that will ensure that you're healthy enough to participate in the study, but we can't give you the study drug until we get those results, which will be a day later. So let's say you come in on a Tuesday, you have that first study visit, and if everything goes well and the lab work turns out well, then you come back on Wednesday and we will give you your first set of drugs so that you can take them home and then take them on a daily basis. Thereafter, you're seen at 3-month intervals over a total of 9 months, and everything must occur at Stanford in our clinical and translational research unit, CTRU. It is a completely non-invasive study. The only thing we will do physically to you is measure thickness of skin, both by calipers and ultrasound. We'll also be measuring the volume of your limbs by applying a tape measure to various points along the limb. We'll ask you to fill out some forms. We will be doing blood work at regular intervals because the FDA wants to know some things about what we see in the lab work during the course of the trial. I've already described the inclusion criteria, and the exclusion criteria are listed here. If you have lymphedema, we want you to complete the initial physical therapy of the lymphedema at least 8 weeks prior to that screening visit. Whatever you're doing to take care of your lymphedema at the time you come to see us for screening, we would like you to continue throughout the duration of your enrollment, because we want to see what the drug does, not instead of what you used to do, but on top of what was controlling your arm to the level that it presents at the time of screening. So we will add the drug onto what you're already doing, and those things like wearing a sleeve during the daytime, or if you use a pneumatic pump, continuing to use the pneumatic pump, if you wear a nighttime garment, wearing the nighttime garment, all of those things, and then we have you take the drug once a day as well. Anybody who's planning surgery for lymphedema will be excluded, but anybody who's had a lymphedema surgery, provided that at least a year has elapsed since that surgery, will be eligible for consideration if there is residual lymphedema that is of sufficient severity to merit enrollment in the study. If you have any other medical condition that could cause or worsen edema, that will not be permitted within this study. And we can't take patients who are either pregnant or nursing at the time of enrollment. I really believe in this treatment. I can't prove it. That's why I need to do the trial, but everything I've done to date makes me believe that we will be able to reverse huge components of lymphedema, and one day using these drugs may actually be able to prevent lymphedema in high-risk individuals. So with that, I'm going to conclude my comments. I do want to give everyone who's watching information in case you are interested in potentially inquiring about participating in the trial specifically. I would ask you to contact my clinical research coordinating nurse by email, and you see her email listed there. Please write it down so that you are able to communicate later. I will look through as many of these questions as I have in the 10 minutes remaining, and I'll try to answer questions that are most generally eligible for elucidating things that the general attendees would be interested in. And I apologize if I don't get to your individual question. Somebody says, are there things I can do to reduce my lymphedema? Is exercise effective? Yes, exercise is very important in the management of lymphedema and in minimizing the impact of lymphedema. And we know that contraction of the muscles within the part of the body that's affected with lymphedema actually serves as an extrinsic stimulation for lymph flow. It increases lymph flow. Now, the problem is if you already have lymphedema and you start to exercise, you will increase lymph flow, but you will also increase blood flow to that part of the body, and the amount of lymph fluid that is formed is proportional to the blood flow to that limb. So if you're not wearing a compression garment and you exercise, you're more likely to make the swelling worse rather than better. So we recommend that before exercise is dialed in as a treatment, that you first are treated by a lymphedema therapist to minimize the degree of lymphedema that you have, and to get a prescription for a compression garment, which you can wear during exercise. And then absolutely doing the exercise is going to be very, very helpful. Somebody asked about whether diet helps lymphedema. The short answer is no. There's no evidence that any diet really materially influences the severity or the presence of lymphedema. Can lymphedema improve on its own? No, generally not. If you get to the stage of overt lymphedema, as I've tried to demonstrate through our research work, you've already initiated all of the molecular forces in the body that are driving the disease forward. And spontaneous resolution of lymphedema is virtually unheard of. It is by nature slowly, or sometimes even not so slowly, progressive, but it is my experience that in any given individual, the lymphedema will continue to progress until it reaches the plateau level that is appropriate for that individual. So you may progress just to early stage 2 lymphedema and stop, or you might be somebody who has a tendency to progress to rather severe disease. And I'm afraid we don't have good predictors for why that does or does not happen. But the best way to reduce the likelihood of progression is to aggressively use the treatment modalities that we know help. Somebody asked whether lipedema advances to lymphedema. The answer is yes, but not always. We call that stage 4 lipedema or lipolymphedema, but I want to hasten to say that it isn't a linear progression. It isn't that you progress from stage 0 to 1 to 2 to 3 to getting lymphedema. You can leapfrog from relatively mild lipedema into components of lymphedema as well. So that's a complicated issue, and we don't know very much about it yet. Somebody asked, what are the best non-invasive treatments for lymphedema? Well, we believe that the suite of treatments that we call decongestive lymphatic therapy, which are those things that are performed by a lymphedema therapist, are going to work in a complementary fashion to minimize the lymphedema. So there are components of lymphatic massage There is often multi-layer bandaging during the acute treatment of lymphedema. There may be use of pneumatic compression devices adjunctively. And eventually, what we're trying to do is to progress to the point of being able to measure the individual for the application of compression garments that can be used during resting periods as well as during physical activity. We like to dial in exercise, as I mentioned before. There is skin care that is a very important component of lymphedema, and there may be adjunctive devices that are utilized as well. Somebody asked, how can I get into one of your trials? Well, I hope I've illustrated the inclusion and exclusion criteria for the trial that we're about to launch. If you fit into that broad category or you think you do, I hope you wrote down the email address and you can simply send an email that says, I'm interested in participating. Maybe tell us a little bit about yourself so that we know whether it's something we should pursue further with you. Okay. Is there a relationship between obesity and lymphedema? Absolutely, and it's a bidirectional relationship. So what we know about obesity is that there is an interplay between lymphatic function and the biology of the fat storage cells themselves. So these we call adipocytes, and adipocytes, when they are abnormal because they're growing because of obesity, they adversely affect lymphatic function. Conversely, or on the flip side of the coin, when a limb develops lymphedema, one of the structural changes that occurs inevitably in the limb is overgrowth of the adipose storage cells themselves. So there is fat overgrowth in the affected limb. So it is a bidirectional relationship. But obesity is one of the rapidly growing subtypes of lymphedema that we're currently seeing in the American population. Somebody asked, were the participants of the first human trial of all stages of lymphedema? The answer is yes. We had not stage 0. And we required stage 2, which is pretty much where everybody gets to by the time they see a doctor with lymphedema. It's rare to even see a patient in stage 1. It tends to be more of a transient course, but we did see all ranges of severity within stage 2 and stage 3. We had both primary and secondary lymphedema. We had both arms and legs. And somebody asked about how to refer people to the trial. Again, I would use that email address that I mentioned. Age range, let me reiterate, is age 18 to 75. Somebody asked, what kind of MD should a person see if they suspect that they have lymphedema? That's a difficult question to answer because lymphedema physicians are distributed across a broad spectrum of specialties, and many, many physicians remain relatively ignorant, unfortunately, about the path of diagnosis and treatment for lymphedema. So the most important question is to ask your doctor if they feel comfortable evaluating it. But among the specialties that could be consulted, I think one that we see very commonly is vascular medicine or vascular surgery. It could be a cardiologist, it could be an oncologist, it could be a doctor who specializes in physical medicine and rehabilitation. It could be a dermatologist. It could be a generalist, a family practitioner, or a general internist. So important to find out if the doctor feels comfortable with that diagnosis. So at this point, I apologize. I see there are some additional questions that remain in the Q&A box, but I'm afraid I have run out of time. So I want to thank you all for your active attendance and participation. I see many of you have hung in there, and I've tried to do the same. Thank you for your interest in lymphedema, which is an important part of my life, and I hope to come back and give you some very successful answers in the near future about our trials and other discoveries that we're making in the laboratory and also in the clinic. Thank you very much. I really appreciate your attendance.